Good afternoon. Welcome again to Grand Rounds. Please remember to fill out the attendance record at the back of the auditorium, and also please remember to fill out the program evaluations and give us any ideas that you might have in regards to future topics or future speakers. Today I have the pleasure of introducing Dr. Byron Vandenberg. Dr. Vandenberg holds multiple board certifications. He's board certified in internal medicine, cardiology, echocardiography, nuclear cardiography, and perhaps most germane to today's topic, clinical lipidology. He is associate professor in the Division of Cardiovascular Medicine and clinical associate professor of internal medicine at the University of Iowa, and we're quite pleased that he was able to find time in his busy schedule to come join us today and update us on lipid management, how to treat lipid disorders in 2018, and please join me in welcoming Dr. Byron Vandenberg.
Thank you. Oh, thank you. Please, thank you for that introduction. Good afternoon, and today we'll talk about managing patients with lipids. And some of you may not be directly involved with lipid management, so I'm going to try and spend a lot of time on physiology and just concepts, but we'll also dig into some details like doses of drugs as time allows. Now, I might need a little help on advancing. Let's see. Someone could help me. Anybody? Is there a clicker or? Oh, here we go. Now we got it. Okay, now it's working. Okay. So this is the outline. I thought we'd talk about the multiple drugs. And this is kind of the new thing, some of the newer agents for reducing LDL cholesterol. We're focusing really lipid management on LDL cholesterol reduction because we know that LDL is responsible for atherosclerosis. LDL gets oxidized, LDL being if you think of LDL as the truck that carries the cargo of cholesterol through the bloodstream, and that LDL particle gets oxidized, it gets under the vascular wall and starts the atherosclerotic process. We know that LDL reduction reduces events. So the first part will be on the specific drugs and overview of what we use kind of in our toolbox for lowering LDL. Then we'll talk about issues of secondary prevention. This is lowering LDL in patients who've had an event, who've had bypass surgery, who've had a stent, had a heart attack. Several of the groups of patients who have clear indications for medications will be highlighted too. So that will be patients with familial hypercholesterolemia. These are typically patients who have genetic reasons for high LDL, most commonly a defect in the LDL receptor, so we don't clear the LDL. Diabetes, pretty standard indication for statin therapy for diabetics. We'll go over that. We'll touch on primary prevention. This is patients who've not had an event yet, and we're interested in preventing their first event. Then statin intolerance. This is a common problem for clinicians. Myalgias can occur probably close to 25% of patients who are on a statin. So we'll talk about some of the strategies. And finally, we'll wrap up with severe hypertriglyceridemia. This is kind of always a concern when you see a patient who has high triglycerides over 1,000 and a history of pancreatitis. And this becomes one of the more urgent visits to the lipid clinic, but we'll talk about some of the management strategies and the workup, importantly, the secondary causes of hypertriglyceridemia. So the first part of the drug talk would be statins, because we have the most robust information on reducing events, not only with LDL reduction with statins, but also in reducing events. And this highlights kind of the major statin trials for secondary prevention and kind of the consistent risk reduction in events. And statins work, just to review that, there's an enzyme that's inhibited, HMG-CoA reductase, and if we inhibit that enzyme downstream, we reduce hepatic cholesterol. So it's not just reducing the hepatic cholesterol that's important, it's the signals that are sent to the liver cells to upregulate receptors to increase clearance. And that's what the Nobel Prize was given in the mid-'80s to Michael Brown and Joe Goldstein for developing that concept of the signaling pathways of you reduce the intrahepatic cholesterol levels, signals are sent to the liver cells to upregulate the receptors and increase clearance. And we have 7 statins now that are available, and the niches for the statins have to do with some of the pharmacokinetics, and I've highlighted in yellow kind of the major themes, hydrophilicity or lipophilicity. So if a statin is water soluble, the theory is that it has a harder time getting through the cell membrane. So if the cell membrane is a muscle cell, this concept of switching a statin, say if you're on atorvastatin or simvastatin, lipophilic statins, to try a hydrophilic statin. That's where this idea of, we'll touch on this more with statin intolerance. The enzymes that are involved in metabolizing statins vary, and this comes into play, and we'll talk about this in a second, about possible drug interactions being a problem when you're faced with a patient who has myalgia on a statin, to just make sure that the medication profile is reviewed. And then to switch from a statin that's using the 3A4 system to maybe one that doesn't involve cytochrome, pravastatin, for example, or rosuvastatin, the 2C9 system. The half-life is, that aspect is used in one of the strategies of the statin-intolerant patients, where we do intermittent dosing. And if you do intermittent dosing of a, if you do intermittent dosing of a long-acting statin, like atorvastatin or rosuvastatin, and give that twice a week instead of daily, we have 80%, the lipid clinics that have reported this, and I'll show you that in a minute, 80% tolerate that kind of a strategy. Now, we don't have outcome data like we do on those daily statin trials, but we can get LDL reduction of about 30%, not 40 to 50% with these potent statins like atorvastatin and rosuvastatin, but that in combination with some non-statin therapy can frequently get us to 50% reduction, which is the goal for secondary prevention and familial hypercholesterolemia. And then finally, the renal excretion plays into patients who have chronic kidney disease. So atorvastatin has very little, relatively little renal excretion, so this is favored by a lot of the nephrologists in the kidney patients. Excuse me. So let me just step back. So sometimes when we're initiating a statin, we want to profile patients for potential risks that might set them up for complaining of myalgias or developing myalgias. So impaired renal function, if you have a renal excreted statin, for example, is there a history of muscle disorders? Prior myalgia is a setup. Liver test abnormalities is another problem with statins, although less common, about 1% in general and about 2% in the high dose range. When we talked about drugs and advanced age warrants reducing the dose of a statin. Monitoring CPK, it used to be recommended to get that initially in patients before a statin. It's not recommended now unless there's a history of myalgia, and then a drug therapy that might be increased, that might be associated with the risk of myalgia. Monitoring ALT just before initiation, and the new record, the labeling has changed because elevated transaminases are so rare, it's not necessary in follow-up unless somebody has symptoms of hepatic disease, symptoms of hepatotoxicity. One of the guidelines that kind of changed the approach of using targets was a guideline that came out in November 2013 by the American Heart Association in association with the American College of Cardiology, and they just used the idea of putting patients on a moderate or high-dose, high-intensity statin. We'll go over that, but they included in their guideline a caveat about is it possible that LDL levels are too low? You know, there's this issue of what's called diminishing returns. We know there's a relationship between LDL and outcomes, and that relationship is not a line, it's a curve. And so when the curve flattens out, we get diminishing returns. As the LDL gets lower and lower, you don't really have much of a change in outcome. And the American Heart Association came up with this, just a guideline really of 40. Once it's under 40, to start thinking about cutting back. And this is just a guideline about when to check lipid panels after starting a statin. One of the safety concerns that came out in FDA labeling a couple of years ago was the issue of new onset diabetes. I don't know, has anybody heard about that? I'm just curious. Can you raise your hand if you've heard about that from any of your patients? You know, it's in the internet, and it is an issue. The Jupiter trial was one of the trials that showed that there was a increased risk of developing diabetes, and I'd just like to touch on that just as a kind of give you some background and some information on what the recommendations are. It looks like it's mostly patients who are potentially at increased risk for diabetes in general. So the recommendation is to just do a screening for patients who are potentially at risk already of developing diabetes. So it's overweight, inactive, diabetes in the history, HDL. So this is a metabolic syndrome panel, low HDL, high triglycerides, polycystic ovary disease, already with a hemoglobin A1C over 5.5, and then to follow up on glucose control on a statin. And so there's this concept of risk-benefit. What's the risk of diabetes? Two organizations have weighed in on this concept. This is the National Lipid Association Task Force on Safety. Their risk-benefit balance goes like this. For every one new case of diabetes, which occurs in 1,000 patient years, so this is basically a statistic that's based on treating 250 patients for 4 years, and that's what the statin trials did. Most of the statin trials were 4 or 5 years in duration. So if you have a statin trial and you have a group of patients who are treated for this duration, you'll anticipate one new case of diabetes, but the trade-off is you'll prevent 5.5 coronary heart disease events. The American Society of Preventive Cardiology estimated at 9 events per one new case. So you get the feeling that there's this risk-benefit. Here's the increase in hemoglobin A1C in the Jupiter subjects. Again, this was the trial that used moderate dose rosuvastatin in primary prevention, and you can see there was just a minor increase in hemoglobin A1C on that trial. And from other trials, this is the CARS trial, the heart protection trial, you can see that you can anticipate an increase in hemoglobin A1C of less than 0.3%. And there's various mechanisms that have been proposed why that happens, including impaired insulin excretion. Another labeling change, in addition to the diabetes issue on the statins, had to do with the issue of anecdotal reports of cognitive issues and potential for patients complaining of maybe some more nonspecific confusion. So these are the recommendations. The task force was set up to look at this from the National Lipid Association. They suggested that if your patient complains of cognitive, I always like to get feedback. Anybody have patients who have thought they had worsening, maybe dementia or confusion on a statin? It's in the labeling. It's on the internet. It's definitely out there. So these are the recommendations to consider. Let's see. First of all, to evaluate for other causes that might have vascular disease, or in the elderly patients who have the substrate for the potential for developing dementia, to evaluate for that. The suggestion is to lower the dose, you can stop it, and here's this issue of hydrophilic statins again, to switch to a hydrophilic pravastatin or rosuvastatin as an alternate approach, especially for secondary prevention patients. The new standards for medical care and diabetes was issued a couple months ago by the ADA, and they made a statement: fear of cognitive decline should not be a barrier to statin use in individuals with diabetes and a high risk for cardiovascular disease. So there's this issue of, a lot of the studies, a number of studies didn't show any change with the statins, but there are these anecdotal reports, and it's out there. Let's move on to Ezetimibe. This is basically considered the second-tier drug for lowering LDL, especially in patients who are statin intolerant or have very high LDLs, the familial hypercholesterolemia group. Ezetimibe, or Zetia, works by blocking cholesterol transport across the intestinal lumen. There's this transport mechanism. It's called Niemann-Pick protein, and if you block that, you decrease the absorption of cholesterol from the intestinal lumen. So that, and then it just goes out in the stool. There is no outcome, just as opposed to all these trials with statins that have shown improved outcomes with statin therapy, there actually is no monotherapy ezetimibe study that shows a decrease in outcomes. It may, but we don't have a specific outcome trial. It probably won't happen because it's generic now. But there is an add-on trial. So this is the trial that's always talked about, Improve It. This is where patients who had acute coronary syndrome, so right out of the box, this may not apply to your patients who have chronic, stable ischemic heart disease, but they added it to moderate dose simvastatin. So this is, the assumption is that maybe we can extend this to patients, for example, who have moderate doses of atorvastatin, 10 milligrams, for example, who don't tolerate going to 40, which is considered a high intensity. You could add ezetimibe, and your evidence base would be the Improve It trial that showed improved outcomes. And again, this is just the Kaplan-Meier curve showing improved outcomes with the Improve It trial. Recognizing within the group of patients who were treated, there's a spectrum, and so they did some more analysis and found that you can profile patients who have a better outcome, and this is just a list: patients with heart failure, hypertension, elderly, diabetes, coronary bypass surgery, chronic kidney disease, smokers. These had the even greater risk than the group in general. It does require a normal liver function because it goes through intrahepatic circulation, so liver tests should be monitored on ezetimibe. The third line is bile acid sequestrants. Bile acid sequestrants basically are medicines like colesevelam, which is a specific bile acid sequestrant. The older generic ones are cholestyramine and cholestopol. Basically, the idea here is if we hold on to bile acids and have them go out in the stool, signals are going to be sent because we need bile acids. We need bile acids to metabolize to break down the fats in the diet, because the fats don't get absorbed. They have to be changed to fatty acids, and all of that going from fat to fatty acids requires bile acids. So what happens? Well, if we decrease bile acids, the level of bile acids, all these signals are sent out to this enzyme to move cholesterol to bile acids. Bile acids come from cholesterol. That's why we need a certain amount of cholesterol. We need some cholesterol to make bile acids, to make cell membranes, to make hormones like vitamin D. Well, we need it to make bile acids. And when that happens, just as we do with statins, remember when we decrease hepatic cholesterol, we increase LDL receptor expression. So that's how bile acids basically have the same mechanism of action as statins. They increase clearance. So LDL is regulated by production and clearance. These medicines increase the clearance. Colesevelam has a spin-off of reducing hemoglobin A1C and actually has an indication as adjunctive therapy in diabetes because it will lower hemoglobin A1C. And so this is kind of a favored lower tier drug when you have a diabetic who's not tolerating a statin because you get the secondary benefit of hemoglobin A1C reduction. Caveat is it will increase triglycerides, and they should be avoided if baseline triglycerides are over 300 and stopped if they creep up to over 400. Because once we get over 500, we can have postprandial elevation in triglycerides that can be excessive, and once we get over 1,000, we worry about chylomicrons plugging up the circulation of the pancreas and precipitating pancreatitis. So let's move on to the newer therapies, PCSK9 inhibitors. Again, I'm just for curiosity, anybody have a patient on a PCSK9 inhibitor? This would be Praluent or Repatha. So this has changed the landscape. These are injectable agents. They're monoclonal antibodies, and there are two that are approved. I just put a list of the indications. Basically, Both are approved for familial hypercholesterolemia, and then patients who need secondary prevention who need additional LDL reduction. So this is typically the statin intolerant, and that's the same indication for both. Just a little background. Basically, the life cycle of a receptor goes something like this. As I mentioned, and this is a cartoon representation, so bear with me. So this represents a receptor. This represents an LDL particle. What happens is for the LDL particle to be internalized, it has to attach to the receptor, and then it moves into these pits, gets internalized, and then the LDL gets broken down, but the receptor gets recycled. Well, we have a system to break down receptors, and that system involves this enzyme, and it's that little red boomerang, and the idea is this PCSK9, if it hooks onto the receptor, it makes it susceptible for degradation. So PCSK9, here's the PCSK9 hooked onto the receptor, the whole thing goes away. So the receptor doesn't recycle if it hooks onto PCSK9. So there is a rare disease of gain of function of PCSK9. So if you have that disease and you have a lot of PCSK9, more than you should, what happens to the LDL? It goes up because we lose the receptors. So the idea is, let's get rid of PCSK9. So they made an antibody, and that's PCSK9 inhibitors, and that's the idea. Get rid of the PCSK9 and have more receptors that go to help with clearance. And if we give the injections once a month, you get this jagged LDL, you get this up and down, you get peaks and troughs of the LDL level. But you get smoother levels if you give it every 2 weeks, and that's the idea. So basically, you either give the agents every 2 weeks or a very high dose once a month. That's the dosing. So here's alirocumab, otherwise known as Praluent, starting to 75 milligrams every 2 weeks. You can give the higher dose of 300, but this has the opportunity to go up on the dose. Here's the other agent, evolocumab, otherwise known as Repatha. Again, every 2 weeks. This is a different milligram, but that's the idea. Give it every 2 weeks, and that's has LDL reduction. Safety was noted in the phase 3 trials. The only little red flag was this neurocognitive issue. You can see it was higher. It was rare, but it was more common than placebo. And other studies it depends how you measure it, and they've studied it and really shown that it's not an issue. And now there are outcome trials, and this is really the new thing in the last year. Both agents do have outcome trials. I think in the interest of time, I won't go into a lot of detail here, but this is the Fourier trial. Again, So these were stable patients. This is the Repatha or the evolocumab trial. These were considered stable patients as opposed to the other trial, the Odyssey trial, patients who had acute coronary syndromes. They were on background statin. You just had to have an LDL over 70, so they were pretty well treated, but not this 70 target has been advocated by a number of the guidelines. And then they followed them, and you can see had a big reduction. So not the 20% reduction that we have with Zetia, not the 20% reduction we have with the bile acid sequestrants, but over 50% reduction, which is what we would see with the potent statins like atorvastatin and rosuvastatin in high dose. So big LDL reduction and reduction in events, although not as great a reduction, not an absolute reduction that we see with statins, but these were already on statin therapy, but still had a reduction in events. LDL reduction, again, over 50%, improved outcomes, and safe and well tolerated. Similar rates of neurocognitive events in this study. And what they did was, this was just presented a couple months ago, the idea was, well, patients who have coronary disease they're not all apples. There's a spectrum. And so what they did was, let's look at the spectrum of disease. And so they looked at it a number of ways. They looked at If you had a recent MI, you got more benefit. If you had more than 2 or more MIs, you had more benefit. And if you had multi-vessel disease rather than single-vessel disease, you had more benefit. So as measured in these 3 characteristics, it gave us kind of some sort of guidance in terms of how hard to push, basically, PCSK9 inhibitor therapy. Odyssey trial, I'll just go over this again. This is just presented a month ago and published a month ago. Patients with acute coronary syndrome, so these are more unstable patients. Again, on therapy, inadequate control is defined as an LDL over 70. Again, looked at outcomes, and they pushed the LDL to 50. If you were just over 70%, you'd expect your LDL now to be in this very aggressive range, although they stopped it if you were under 15, a very low bar. And efficacy was shown, although what the interesting thing about this trial was, again, they looked at spectrum, and what they looked at was your starting LDL. So the patients who had an LDL over 100 had the biggest benefit. So again, they took people who if you were 71, you got in the trial, but the big benefit was if you started it at the higher dose. And that's consistent with the statin trials. The statin trials showed that the higher the risk, the more reduction. Okay, clinical perspective, no safety signals in this study. And again, this is just a summary, again, reduced events. We used to do, as many people did, apheresis. For anybody ever have a patient on apheresis for familial hypercholesterolemia? This is not very common. It's definitely not common now because we don't do it anymore with PCSK9 inhibitors. I won't go into details because this is more of historical of interest. Basically, two venous cannulas, blood goes out, blood gets filtered, blood goes back in, so no pills are given. This is basically, we used to do this for statin intolerant patients who have coronary disease. I'm just going to skip through that. Okay, let's talk about secondary prevention. So this is the guideline. Basically, if you've had a heart attack, you should be on a high-intensity statin. That's the AHA guidelines. The caveat is if you're over 75, you're at increased risk for myalgias, so the recommendation is to use a moderate intensity statin. That's basically the bottom line for this slide. And here's how that statins are categorized. We talked about 7 statins, and here's how they plug into the different intensity. We'll really focus on the high and the moderate intensity group, but in red is the key one. After a heart attack, patients should be on a high intensity statin unless they're over 75. This is kind of the big thing. Anybody have any questions about this? This was the AHA guideline. It came out 2013, and it was a big deal because that changed the paradigm. The paradigm had been LDL under 70 if you have for secondary prevention for the very high-risk patients. Their idea was that the studies, basically the studies that had showed high-intensity statin were of value didn't use targets. Basically, those studies, they compared moderate to high dose, and the high dose had reduction in LDL and events. These are the events. The event rate was improved. Now, granted, the average of the peak, the LDLs on therapy had this, normal distribution, but the peak was around 70, so that kind of got the 70 number. But the AHA said, well, let's just have clinicians focus on get them on a high-intensity statins because that's what the trials did. But other guidelines, this is where it gets a little confusing for clinicians because there's a lot of guidelines out there. Well, the National Lipid Association a year later said, no, we think targets are important. So 2 different perspectives, and one of the things I'm going to try and do is kind of synthesize all these different perspectives. This is what the National Lipid Association said about patients who have coronary disease. Targets, LDL under 70. So this is non-HDL and LDL. By the way, non-HDL is just something that's calculated from the standard lipid profile. It's total cholesterol minus HDL. HDL is the good cholesterol. It's involved with what's called reverse cholesterol transport. That's where we take cholesterol out of the vessel wall and bring it back to the liver. That's what HDL does. Everything else is bad. So what I mean is VLDL, these are the trucks that carry the cargo. VLDL, very low density lipoprotein, is more buoyant. That has mostly triglycerides. That gets hydrolyzed down to intermediate density lipoprotein, and LDL, low density lipoprotein. All those carry what's called a little marker, apolipoprotein B, and those are the atherogenic particles. And you pick that up cheaply with non-HDL. And the reason it's important is we have what's called residual risk after LDL reduction. The residual risk is based on all these other particles beyond LDL. So that's VLDL and IDL. So there's two goals here for coronary disease. It's a goal LDL under 70, non-HDL under 100. So that's the kind of with the older pre-AHA guideline, but you can use them both together. The European guidelines said the same thing. They came out in 2016. We want targets. The American College of Cardiology came out last year with a update. Again, they're going with targets. LDL under 70 for secondary prevention. I think I'm going to go right, unless there's anybody. The other thing I always like to do is just provide, if anybody feels they have a gap in the information. Any questions about secondary prevention? So let's go to familial hypercholesterolemia. The recommendation is, as opposed to, and this relates to patients who've not had an event. If you're faced with a patient who has FH, we'll just use FH as familial hypercholesterolemia. As opposed to primary prevention in patients who don't have really high LDL, we'll talk about risk calculators in a second, but it's not recommended for FH. Their LDLs are so high, over 190, that they right out of the approach should be just get that LDL down by at least 50%. So that's the recommendation after you look for secondary causes of hypercholesterolemia. These would be things like hypothyroid, medications. I'll show you a list of those. High intensity statin, unless contraindicated, achieve at least 50% reduction, and you may have to add another drug to get that greater than 50% reduction. So here's the secondary causes. This is just as when you're faced with a patient who has high triglycerides, you want to look for secondary causes. Here's the list. The classic thing is to divide it into the three groups: diet, drugs, diseases. And this is just a list that people typically go through just to make sure there's not a secondary cause. There's three major reasons why people have very high LDL, over 190, without a secondary cause. The most likely is a problem with that receptor that we kind of highlighted. There's lots of mutations, over 1,600 at last count. Basically, if you have a mutation, you won't clear. So usually what you'll face is a heterozygous FH. This is where one of the parents gives the faulty mutation. If both parents give it, that's homozygous, but that's 1 in a million. So heterozygous is 1 in 200 or 1 in 300, depends on where you live. That's the most common. We already talked about the gain of function mutation for PCSK9 when we talked about the inhibitors. And the third is you have a problem with the ApoB. That's that marker that's on the LDL that sends a signal to the receptor that it's me, take me in. If you have faulty ApoB, the LDL won't be recognized. And typically if a lot of the insurance providers have asked us to provide information where the patient is on the spectrum of FH. Is it possible, probable, or definite? And this is kind of the standard approach, the Dutch Lipid Clinic Network diagnostic criteria. And this is just a system. You add up points, and based on the points, you give people how strong the diagnosis, where definite typically gets covered, and it gets to be a problem. I mean, I saw the hands went up. I mean, they're typically denied. The requests are denied, and you have to do appeals. Although I would say Medicare typically is successful in getting approval, although our experience has been the copay is 25%. Well, these medicines the PCSK9 inhibitors are $14,000 a year. So if the patient's stuck with a $3,500 copay per year on a fixed income, it can be difficult. Genetic testing labs are definitely out there. I would say internationally, the genetic testing for FH has been widely used in countries like the Netherlands and Norway, but very little here. It has to do with the funding for providing it. But you can see if you have DNA analysis, you get a definite diagnosis of FH. But the irony is that we can't get funding a lot of times to get the genetic testing. Again, the over 190 typically is the number that kind of gets your attention for a heterozygous. Homozygous over 400, and this relates to there's a couple new agents that have been approved for homozygous. This is a real rare disease. This is the treatment algorithm that was proposed by the American Heart Association, kind of the stepwise, start with high-intensity statins, then the second tier is ezetimibe, and this is the third tier. As PCSK9 inhibitors have moved up the ladder in terms of priority with the outcome trials, niacin has, a lot of the guidelines have kind of moved this out because there's less than 6% reduction in LDL with niacin therapy, although this is useful for high triglycerides. And bile acid sequestrants really get moved down into patients who maybe can't afford PCSK9 inhibitors. Bile acid sequestrants and ezetimibe combination is used very frequently in statin intolerant patients who can't use PCSK9 inhibitors. This is the FH recommendations from the American College. After statins, their second tier is basically either ezetimibe or PCSK9 inhibitors, and then to add other things like bile acid sequestrants as a third tier. Any questions about FH? Let's move on to diabetes. Really, the number of studies have shown that all diabetics should be on a statin. The AHA suggests moderate intensity statins in general, and then high intensity if you have increased risk. This is this risk calculator I was telling you about. We'll talk about more of this in the primary prevention section, but basically you can get this on your iPhone, your app, to calculate risk. We'll talk about how they pick 7.5% a little bit later. The uncertainty has to do with diabetics under 40 because there's just not that much as much trial data. This is from the National Lipid Association. Again, same idea as the AHA, this two-tiered diabetes with no risk or maybe one risk factor. Go LDL under 100, but if you have multiple risk, which would be the higher risk on the AHA, the higher intensity statin, high intensity because that's where we get 50% reduction. Moderate intensity statin gets 30 to 50% reduction. This is from the standards of care document from the ADA that just came out. Their concern is that risk calculator doesn't account for duration of diabetes or the presence of other complications of diabetes. They suggest for primary prevention, moderate intensity statin over 40, again, because that evidence base is stronger over 40. Consider high intensity of additional risk factors. In terms of getting to goal, the other organizations suggested adding ezetimibe as a backup, and we talked about that already. Ezetimibe really is the theme. The second after statin, when you're going to a non-statin, ezetimibe emerges. It's a small pill, take it once a day, versus the bulky bile acid sequestrants. For secondary prevention, the ADA in their recent documents suggest high-intensity statin. Again, because they're increased risk. This is also based on a lot of information. The Cholesterol Treatment Trialist Collaboration every few years redoes their database and basically very strong evidence of reduction in events. The evidence for adding non-statin therapy, there are about a third, 25 to a third of patients in the Improve It trial and the Fourier trial were diabetics. And so in the subset analysis, they could show that there were improved outcomes with these add-on agents to statins in diabetics. So if you have secondary prevention in a diabetic who's not tolerating a statin, ezetimibe, at least some statin, you have the Improve It trial as your evidence base, and then Fourier. This is from the Endocrine Association. I just wanted to touch on it. This is kind of for the internists in the crowd. You know, there's actually an ApoB that you can measure in most labs, and this is useful for metabolic syndrome. When patients have an LDL that's at goal, it may send you the wrong message, because if you have metabolic syndrome, you have this concept of small LDL, you have low HDL, high triglycerides, and when you fix that, now the LDL gets bigger and has more cholesterol, so the LDL will go up because we're measuring concentration. Well, if you have a small LDL under 70, one thing you can tease out is the particle count, which you can get indirectly by just measuring an ApoB level. So the Endocrine Society has suggested these cut points. Under 80 would be the similar, if you wanted to have somebody who's a high-risk diabetic, make sure the ApoB is under 80. So the little niche there is for metabolic syndrome. ApoB, again, is that marker on the LDL that helps recognize. I think for time, because we wanted to have some time for questions. Any questions about statins with diabetics is pretty ingrained in the literature, pretty solid. There's not much question between all the different guidelines. So primary prevention, this is that risk calculator I was mentioning. It's basically, you can get it on your device and calculate risk. It's based on a number of different variables, big database. The one confusing thing about this is what's the cutoff? The AHA uses 7.5%. It was a little arbitrary, but that's the number if you look at the guideline. Again, that just talks about the risk calculator. I'm going to skip that. And this idea of a cut point comes from this. Again, this is the cholesterol treatment trial list. They redo this graph. It's kind of the classic graph that's shown in cholesterol management talks. Basically, it's an XYZ graph. So on the Y is major vascular events avoided. Here's LDL reduction. So in this direction, this is starting from where you're starting to where you go, the greater reduction on therapy. On this axis is what is that 10-year risk. So the big bar is going to be the group who has the highest risk group, who has the greatest LDL reduction, is going to get the greatest reduction in events. Okay, so they're getting the biggest bang for the buck. I mean, they're getting the best benefit. But that benefit attenuates as you move down in terms of the risk category of the patient. At some point, it becomes the balance does not favor statin therapy. And the question is, where's that line? So the AHA has picked 7.5%. Here's where it gets confusing. U.S. Preventive Services Task Force thinks well, maybe it's more like 10%. The National Lipid Association is maybe closer to 15%. So there is, in terms of the confusion within all these guidelines, it's that cut point. There's definitely this concept of as your risk goes up, you receive more and more benefit. It's just the controversy is where's that cut point? The NLA, National Lipid Association, suggests, look, let's just look at risk factors. And basically, what they suggest, and this is primary prevention, because I think this is the one where a lot of questions come up that we get in the clinic is, we have the typical scenarios. I have this 40-year-old patient who's got an LDL of 170, who has nothing else. His risk calculator is 4%. So it doesn't matter who you read, they wouldn't put a statin, but his father died at 39. And so there are some things that you can look at to maybe reclassify patients to a higher risk than just looking at traditional risk factors. One is the actual LDL. So National Lipid Association and American Heart Association actually uses this 160 number to consider drug therapy. Let me go, and so this is what I'd like to highlight, because this comes up a lot of times with questions about the individual patients. So the AHA gave this suggestion. This is factors that might consider reclassification, and I would say one easy thing to remember, a question that comes up is there a blood test I can get on this patient who I just described that maybe would push me? And the two things would be lipoprotein A level. Lipoprotein A is LDL with a little extra protein. It's called a kringle that puts LDL patients with whatever, two patients with the same LDL, if this patient has a high lipoprotein A, that is at high risk LDL, their risk goes up. So lipoprotein A over 50, that's the National Lipid Association, or CRP over 2. But there's other things too. So I already mentioned LDL over 160, evidence for genetic dyslipidemia, elevated lifetime risk. So there's a risk calculator does anybody, this is just for me. Anybody use the risk calculator? The pocket thing, it's on your phone. Super useful, but they also give you a lifetime risk. And so that's useful if somebody's under 40. So 45% lifetime risk has been suggested as another thing to push you on the younger patients. Family history, we talked about CRP, ankle brachial index, non-invasive index of peripheral vascular disease, coronary calcium score over 300, or use the age-related. Anybody use coronary calcium scores, just out of curiosity? And then here's the National Lipid Association, again, similar things, but the caveat is that lipoprotein A is a kind of a useful biomarker if you're on the fence. Primary prevention trials, statin intolerance. Okay, I'm going to go do this in a couple minutes, and we'll do triglycerides and then have questions. Typically, patients with statin intolerance, anybody have patients who have myalgia? This is super common. If you'll get ready for it if you're just starting out. The first thing is to look for secondary causes, and the typical is just make sure they don't have vitamin D deficiency or hypothyroid, because both can cause myalgia. The theory is with vitamin D deficiency, remember the body has a way to make more vitamin D, and that system involves the cytochrome system. So if we're tying up the cytochrome system and making more vitamin D, we don't have the cytochrome system to metabolize statins, so what happens to the levels? They go up and you get muscle aches. So the recommendation is to get that vitamin D level over 30, although the data is not a double-blind randomized trial. It was not the greatest study, but that's in the literature to try and get the vitamin D over 30, because patients seem to tolerate, at least in that study, and I think anecdotally people would agree with that, because you see this all the time in the meetings. Fix vitamin D, fix hypothyroidism, because again, it affects the metabolism of the statins. So this is basically suggestion from American Heart Association, American College, pretty much standard approach towards patients when they come in. Stop the statin and get rid of the symptoms, because the likelihood of compliance, if you're hurting, is not very good. So get the patient asymptomatic. Most people would suggest a re-challenge, but at least try another statin. At least 2 to 3 statins has been kind of used as a criteria for true statin intolerance before we get into PCSK9 therapy. We talked about alternative dosing strategies, using it 1 to 3 times a week with the longer acting agents. So this is basically what happens when you have drugs that interact with the cytochrome system. If you take statin and another drug that interacts with the cytochrome system, you have decreased statin metabolism, the blood concentration goes up. That's pretty straightforward. And lots of medicines, there's a list. There's actually an app that I'll tell you about for statin intolerance that makes it real easy. You just click all the drugs that the patient's on and it'll tell you. But these are basically the groups. You see antibiotics, calcium blockers, antiarrhythmics. And for the cytochrome 3A4 drugs, the one that's relevant is simvastatin, because it actually has specific labeling in terms of being cautious about the doses you're giving if patients are on calcium blockers like verapamil or diltiazem, or antiarrhythmics like amiodarone. There's amlodipine, ranolazine. Restricted dosing for starting 80. We're not supposed to start 80 anymore unless you're assuming care of a patient who's been on 80 milligrams for at least a year, because of the increased rhabdomyolysis risk. 2C9 agents, again, this is just a list just to make you aware of drug interactions. Intermittent dosing, I've already talked about that. This idea, these are the various lipid clinics that reported this idea of intermittent dosing, LDL reduction, 30% tolerance in 80% of patients who had, and this included patients who had liver test abnormalities as well. If the CPK is over 5 times upper limit, you should make sure that you do a careful questioning about rhabdomyolysis. urine testing, creatinine testing. That's the big, very rare, but definitely something that is an urgent issue. Typically, patients get resolution of the pain by about 3 weeks. There's this range of 2 to 4 weeks. If the pain persists for significantly longer than that, you always just worry about or wonder about unmasking an underlying metabolic myopathy. And CK elevation is not specific. A number of things can cause hypothyroid, alcoholism, ethnicity, medications, and this again, if you have elevated CK that persists after stopping a statin, you wonder about unmasking an underlying myopathy. This is a screenshot of the app I was telling you about. Super useful, just in terms of, especially I like it because of the medication profile, and it gives you can tie in your history. Finally, severe hypertriglyceridemia, just a little kind of a background of terminology. Triglycerides, remember, are 3 fatty acids hooked onto a glycerol backbone, and then that triglyceride is transported in VLDL. This is the spectrum. We talked about the trucks that carry the cargo. VLDL and chylomicrons are the trucks that carry the triglycerides. And this is just a slide just defines what the severity is. The 2 associations have kind of little nuance in terms of the difference, but basically over 1,000 for endocrine society. That's kind of the standard severe, because that's when you're really worried about pancreatitis. That's what diving into hypertriglyceridemia is, to prevent pancreatitis or recurrences of it. I'll just tell you about the first thing. There's this controversy about causal factor in cardiac disease, just isolated hypertriglyceridemia because of the issue of metabolic syndrome. The risk probably has to do with metabolic syndrome, the low HDL, high triglyceride axis being off. Just as with somebody who has high LDL, the recommendation is to look for secondary causes. Again, it's the diet, drugs, disease idea. Some overlap, hypothyroid, you can see, medications, excess alcohol. Alcohol is used as an energy substrate, so we don't need the triglycerides as an energy substrate, so they get stored. Alcohol abstinence becomes a key part of therapy. The drugs that can cause elevated triglycerides vary in their mechanisms. We talked about alcohol. You can see some of them increase VLD production. Some of them affect the enzyme that's related to converting VLDL to the smaller particle. That's called lipoprotein lipase, LPL. First part of treatment is diet and exercise, avoiding fats, avoiding simple carbohydrates, kind of the diabetic diet. And alcohol abstinence, weight loss alone can lower triglycerides. And so when we get into this very high group, near zero added sugar, 10 to 15% fat, avoid alcohol and exercise. That's kind of the standard non-drug first thing to do with hypertriglyceridemia. And that's because it works. You can see triglyceride lowering response. The package, you can get significant reductions. Then we talk about drugs. The go-to drug are fibrates. That's the biggest reduction. Niacin, omega-3 fatty acids. Statins, 30% is probably generous. Most trials would say you get about a 10%, but these are the big 3 are fibrates, niacin, omega-3 fatty acids, and typically a lot of the people who have high triglycerides are diabetic and they're already on a statin. The easiest way, at least for me, to think about how to approach from a combination drug therapy, a patient who has high triglycerides, is the point of attack. And so we have three targets of therapy. One is reduce the lipoprotein lipase. We want to reduce the fatty flux to the liver. That's niacin is really useful for that. Reducing the formation of, increasing hydrolysis, increase the expression of LPL is what the fibrates do, and reduce the formation of triglycerides in the liver. So triglycerides are made in the liver by putting 3 triglycerides together, and niacin inhibits that. Okay, fibrates do multiple. The big thing is to increase expression of LPL. It does have some effect peripherally and in the liver. I think I'll just skip the big thing, the take home on fibrates is the evidence that it saves, that reduces cardiac risk is very thin. The best evidence is this last trial, the Accord trial, because this is more of modern day where we had people on this is a diabetic trial, patients on statins. You can see it didn't quite reach significance when they did the post hoc analysis on patients who had metabolic syndrome. So to say fibrates reduce cardiac events is thin, very thin evidence. It's a trend at best. Niacin again works peripherally. The only thing about for clinicians is if you start niacin on a patient with hyperuricemia, you can precipitate a gout attack. So don't forget baseline uric acid. You can raise blood glucose. Again, statins for triglyceride aren't really that effective. I just summarized all the statin trials. You get less than 20% reduction in triglycerides. Omega-3 fatty acids, again, ApoC is a cofactor for LPL. I'll just, if we have time, this is probably the newest for the internist. You may be getting stuff in the mail about an injectable, called an antisense. The idea is if we can get rid of ApoC3, we can have more activity of LPL. Omega-3 fatty acids, there is something from Japan that shows improved outcomes, but this was concerned because there wasn't very much background statins. I think I'm going to just skip this. This is just a slide to highlight that there's different omega-3 fatty acids preparations. The over-the-counter typically is a combination of DHA and EPA. There's a lot of interest in just pure EPA. It's controversial. People think it maybe doesn't raise LDL, but people think that, well, omega-3 fatty acids fix metabolic syndrome, so your LDL is going to go up. You go from the small to the normal size LDL. But there is an outcome trial that's pending. This is just if you want to have this on the, maybe in a year we'll talk about this. The idea of the Reduce It trial is to ask the question, if we lower triglycerides with omega-3 fatty acids, will that prevent heart attacks or cardiac events in general? Because that question is not answered yet. Reducing triglycerides with therapy, does it reduce events? We're pretty sure it reduces pancreatitis, although, or lowering triglycerides, but even that it's hard to control that study. And I'll just end with this. This is the new thing. It's an injectable. If we can inhibit ApoC3, we can get LPL activity, and 2 trials, and the thing to watch for is FDA meets in May. This would be the new thing in the field if that gets approved. Any questions? That's it. Whirlwind tour of how to manage lipids. These are the most common questions that come up in the lipid clinic in terms of referrals. So, well, I thank you for the invitation. Thanks, Rain. Got to find out where an Iowa City guy can get a Cyclone sweatshirt. I'm gonna.